Okay. Good afternoon, everyone. Okay, so the only new thing since our last meeting is the state put out a cardiac arrest standard of care. So I'm going to ask Dr. Rabridge and Dr. Wasserman to discuss it with everyone. It's up on, hopefully everybody can see it. It's up on the screen.
I don't see it anymore.
You don't see
Yeah.
it? Oh,
Share your
hold on.
screen.
Let's see.
I'm trying to bring it up on my computer over here.
You see it now?
Yep, there you go. Yep.
Okay.
Yeah.
All right. So, as many of you know, we've been putting out additional protocols and policies regarding cardiac arrest during this pandemic. However, what's important to realize is that a lot of the stuff we're putting out is not specific to this pandemic, and the literature and evidence to do it well predates the pandemic. So a lot of this stuff is based on cardiac arrest research in the early 2000s and well before 2010. So a lot of this is evidence-based. And what happened is after the last protocol, around the same time as that protocol about not transporting people unless you get ROSC, several of us on the CMAC worked on the document we're going to go over today, and it was sent to the commissioner. And the reason it came out this week was that it had to be approved by the commissioner first. So first thing is it's adults only, right? So it applies only to patients over 18 years of age. And you can see that it says right here that these changes are based on well-accepted, widely published evidence, widely agreed upon by the physician leaders of the EMS system, and reflects recommended revisions which predate the COVID-19 public health emergency and are used in many areas of the US and other parts of the world. This is standard operating procedure at all times. So the first step of this protocol, right? So you get on scene. Does the person have a DNR? Do they meet obvious criteria for obvious death, right? If that's the case, then you do not resuscitate. There's no change there. That's nothing new. You're already doing that, right? So you get there, they have any of the stuff that's already in a protocol about obvious signs of death, or they have a DNR, we don't do anything, okay? If that doesn't exist, so that's not the case, then the next question is, did EMS witness the arrest, okay? If EMS witnessed the arrest, right, then you're gonna begin resuscitation. If EMS did not witness the arrest, then you're going to put the monitor on or apply an AED. So at the BLS level, right, it's AED, and is there a shockable rhythm or not? So if the monitor says no shock advised, or at the ALS level, you have a non-shockable rhythm, right, or a PEA, so you have like asystole on the monitor, then you do not initiate resuscitation, right? So why is that part? That part is that if you get on the scene, it's an unwitnessed arrest, and there's a non-shockable rhythm or asystole on the monitor, the chance of resuscitating that person is very close to zero, probably less than 1%. So we don't initiate resuscitative efforts. If it is witnessed, right, we're going to begin resuscitation, or you have a shockable rhythm, then you're going to begin resuscitation. Now, the changes here on this next section are really related to airway management to provide adequate protection. So to provide adequate oxygenation, but the maximum amount of protection for the provider. So again, you're going to be using your appropriate PPE for aerosol generating procedures. Again, that's a N95, right? Eye protection, gown, and gloves. Okay, and you're going to initiate compression-only CPR, put an OPA or NPA in, all right, a non-rebreather, and a surgical mask over that. Now, you can use a BVM with an advanced airway, but you should only do that if a viral filter is present. So I understand from Frank that we do have a very limited supply of these right now.
Yeah, we put out what we have. There's no more. And we've put in orders with 5 different vendors. But, obviously they're in short supply, so I don't know when we're going to get any in. And we've asked both hospitals, but the central supply in both hospitals said they're not allowed.
We have a limited number that we're using
Right.
for our ventilators right now. We don't even have enough for our BVMs.
Right, and that's the other issue on the RMC side is that we have about 100 of the aerosol generating filters, viral filters for the vents left also. So
if you have that available, great. You can use a supraglottic airway with a BVM. Now, again, the supraglottic airway is considered the first line or preferred pre-hospital airway for cardiac arrest patients, okay? That's also evidence-based. So we know lots of studies, right? AHA, several studies showing that supraglottic airway is superior to intubation in cardiac arrest. Then you proceed with your usual resuscitation, right? So then this next part was a little confusing to some people because there's nothing on here that talks about doing ACLS or giving meds or anything like that. So you begin resuscitation, and then basically you do your cardiac arrest protocol, whether that's the VFib protocol, PEA protocol, 20 minutes, right? If you get no ROSC after 20 minutes, then you terminate the resuscitation, which is consistent with the prior guidance that was put out. If you're not sure, or you keep getting rhythm changes or it goes back and forth and you don't know what to do, the key part of this protocol, like every other, is consult medical control. So at any point in here, you can call medical control for advice on what to do. When you get to the point where you want to terminate, you can certainly call medical control to get guidance as well. So that's kind of the intent of this protocol, and the purpose is to minimize risk to the EMS crew, to provide for a single provider to make the initial assessment and determine if it's an arrest that we're going to proceed with resuscitative efforts, and to try and keep everyone as safe as possible, recognizing this is all a risk-benefit reality, right? So what is the potential reward or potential value of the resuscitation? Well, if it's a situation where it's low yield, you're less than 1% likely to resuscitate anyone in that situation anyway, and it's high risk to the provider, then we don't proceed with that, right? So that's the whole point of this protocol. So that's where it came from. That was the discussion at CMAC behind the scenes, and that's how it got developed. So that's kind of an overview of it, but you know, I'm sure Adrian has some comments on it, and we'll be happy to take questions about it.
Can you guys hear me?
Yes.
I mean, I think the most not interesting, but the most interesting thing here is, like, if you get to the scene and per the protocol, if you find the patient to be in asystole, then that's, even if the patient was a witnessed arrest, it happened 2 minutes ago, that's still, it ends with do not resuscitate. So any asystolic arrest is essentially not resuscitated in the field at all.
Actually, it looks like any arrest that we did not witness, right? How does it read?
No, so if you don't witness it, then you,
if
you do the monitor.
Oh, then you go to the monitor, right? Right.
Misspoke, but yeah,
Yeah.
if it's witnessed, then you do the resuscitation. But
Right.
if you show up and it's asystolic, you don't do anything. If there's no witness.
Right. Which we all know from the vast number of asystolic cardiac arrests we've worked over our careers, right? That what is the likelihood of getting that person back?
Very small.
I spoke with the ambulance corps in Ramapo, with the exception of Arvac and Sloatsburg, about this, and there was a lot of, I don't want to say pushback, but there was a lot of confusion about it. So, you know, we went over the concept that when they're going to get there before us most of the times, or some of the times, and that the first thing they should do is put the patient on the monitor. If the monitor says no shock advised, that they're not to resuscitate and they're to cancel the ALS unit, because they were saying, well, should we continue to have the paramedics come in to put them on the monitor to see what the actual rhythm is? And I said, no, if the AED is saying it's a non-shockable rhythm, you know, and you don't have a pulse, you cannot palpate a pulse anywhere, then you're not doing anything. You're canceling ALS and you're, you know, leaving the patient.
Right. Now, I think that several, you know, some of the BLS agencies may still have a problem with that, and they may be reluctant to cancel you guys, and they may just not feel comfortable until you guys get there and confirm that they're doing the right thing. But what Frank said is true. They should, if it's a non-shockable rhythm, they should not resuscitate and they should cancel you.
Does anybody want to unmute themselves if they have any questions on this? Everybody.
Frank, just a quick clarification. I see it says on the bottom that the 20 minutes includes both BLS and ALS total resuscitation time. How does any bystander provided time figure into that?
It
Well, it
doesn't
say
It should be
anything. Yeah.
considered EMS time.
Right.
I have a question.
Go ahead, Rob.
So I actually spoke with 2 of my Nanuet crews about this this morning. They're all on board with that. So at least that was a positive.
Right.
But My concern and question is, again, with these nursing homes. Why, if this is the State Department of Health putting this out, then why are they not doing the same thing? Why are they calling us for cardiac arrests, especially like it's an unwitnessed arrest? I can see if it was like a choking in like the dining room or something, but we're continuously getting called for these cardiac arrests at these nursing homes, and according to this, we really shouldn't be.
Correct. So they shouldn't be. I don't know. We can tell them a million times, which we have. I think they're still going to call you at times. I think sometimes they call the doctor for the nursing home who isn't physically there, or may go there once a month or something, and they say, if they're, I don't know, if they're not breathing, call EMS, right? Call 911. I get it. I think in that situation, one person should go in PPE, confirm the person's dead, and say, have a nice day to the nursing home staff.
Yeah, that's what we've been doing.
Yeah.
Just going in there. I call it four leads in a phone call protocol.
Yeah, pretty much.
And that's what I'm doing.
Yeah.
But you're still exposing yourself.
It's variable success with some of them, trying to get them to understand this. A lot of these nursing home administrators, they either don't get it or don't care, or just want the person out of there.
Listen, when the true numbers come out on what's going on in the nursing homes, it's going to be vastly.
Yeah, there are a lot of hidden nursing home numbers right now.
Oh, yes.
Look at New Jersey.
Yes. Well, I think it's New York too. I heard the other day there are 25 over one weekend in one of our nursing homes.
Oh, yeah.
So.
Yeah, we had 5 in one night over at Nyack Ridge. So.
Yeah.
Yeah. Well, let's not say which locations, but. Okay. So anything.
So the quirk in here, obviously, and I guess this is the way it is, and there's nothing that we do about this, but the quirk in here is BLS gets there first, puts them on the AED. It says no shock advised. They can cancel us and the call's over. They don't do anything. That patient could be in PEA where that's a workable arrest for us. But I guess that's just the fallout from this, correct?
Yes.
Yes.
Fine.
And it's just designed because, right, there's parts of the state that don't have ALS available, or
Got it.
ALS may be busy. So yeah, you have to put it in one document. Yes, that could happen.
Okay, I just wanted to make sure I was clearly understanding this correctly. That's all.
But I don't think it says that you should therefore continue to the scene to make sure it's not PEA.
Yeah. No, I just want to make sure I was understanding correctly.
Yep.
Okay. So any other questions on this latest version of our cardiac arrest management? Okay. Jeff or Adrian, do you have anything else you want to discuss with the medics before I open it up for general questions?
I think that the volume has dropped off in our department, and I'm sure it's similar at Jeff's.
Yep.
We have a decent supply of ventilators. We're discharging patients. Of course, we have a lot of expirations. Our hospital is working to resume semi-normal operations. I'm sure Jeff's hospital is looking to do the same. But our volume overall, non-COVID volume especially, is down. So I'm anticipating at some point when things kind of start returning to normal, we're going to have a flood of people who have delayed care. And so you're going to probably see a lot of that as well soon.
Yeah, we've seen the same thing. There's been a few articles in the press as well nationwide as to, where are all these patients, right? Where are the people with the strokes and the STEMIs and the kidney stones and all this other stuff, like, volume nationwide in ERs is down some places as much as 40-50%, even in areas where there's not a major COVID outbreak right now. So I think people are afraid to go to the hospitals right now. We are working to normalize things. We'd like to restart elective surgeries and stuff. Right now, that's not an option. If you saw this morning at the governor's press conference, he said that there's going to be a phased reopening, but he specifically mentioned Rockland County as one of the counties that will not be included in that. So, as well as New York City, for given obvious reasons that we have so many cases in the region. We do continue to discharge patients. Yesterday, we broke 300 for patients that were discharged home with COVID. Our ICUs are still full. We haven't been able to close any of our additional ICUs yet. While the ER is doing better, we still have patients that are been on ventilators for a week, 2 weeks, you know, and patients on the floor that are still getting worse and ending up in the ICU. So, you know, our hope is that in the next week or so, we can start consolidating our ICUs. But I don't think we're going to see any type of return to any normal activity before early May at the earliest.
Okay. Does anybody have any questions? Any medics, EMTs?
Jeff, my question is this. When should we start considering antibody testing for all of us who may never become symptomatic or, you know, tested positive or, you know, anything? When should we, right. When is that going to even come into play?
So the first thing to understand is how those tests work. And there's two types of antibody tests. There's what's called a qualitative test, which gives you a yes, no, you have antibodies, you don't. And a lot of those tests are out now, but some of them are kind of cheap tests that aren't well made. And a few of them, you know, came from China and they stopped using them because they found that the sensitivity was like not that great on them. And that just gives you a yes, no. It's kind of like a pregnancy test. You put a drop of blood on the thing, you either get a line, you don't get a line, you have an antibody, you don't. The test that everyone's looking for is what they call the quantitative antibody test. That's an ELISA test that they run in a lab and tells you kind of what's your titer, how much antibody do you have, kind of like we do for measles and chickenpox and all those other things that, you know, you routinely get titers for. Because if you're positive on that first type of antibody test, no one knows what that means yet. We don't know, do you have immunity? We don't know. Maybe, maybe not. Maybe you've just been exposed to the virus, but it's not enough of an exposure that you would actually have immunity. So those things are rapidly in development. Quest came out with an antibody test this week. LabCorp is coming out with one next week. I think in the next couple of weeks, we'll have better testing for that, and then it may be worth doing. Right now, the only way to get those type of tests is to be part of the plasma donation studies, like at Mount Sinai or in New York Blood Center, where they would test you in conjunction with donating plasma. But to just get the test now, it's hard to know what that means. And a lot of people who thought they were exposed and kind of, you know, are walking around going, oh, I'm an EMS or I work in a hospital, that have actually gone and gotten some of those tests did not have actual antibody exposure.
So I'll add that our lab received a small supply of antibody, the qualitative test, the yes/no test. They're not, so most of these tests are not FDA approved. So we kind of received them through a backdoor channel. Someone knew someone and donated some tests. And we tried them. So a fair number of people had antibodies that we tested. We tested both patients who we had a known positive test. And we tested some staff members too, who said, oh yeah, I you know, had a cough last week or a month ago or whatever. So the results were kind of variable, and we couldn't really generalize it for sure, although the ones that did have positive tests, if we waited long enough, they did have a positive antibody test. People that were exposed yesterday, it could take up to a month to develop antibodies. So, you know, even if you had a cough last week or, you know, you didn't feel right last week and you went and got an antibody test today, still might be negative, and that might give you just, you know, a false idea of your level of protection, whether you're protected or not. And we don't even know if you have antibodies, if you're protected, and how long those antibodies will last for. And the tests are largely unavailable at this point. We're getting, so supposedly our lab runs Siemens tests, and Siemens is supposed to come out with a quantitative antibody test in May. So we'll probably be getting some in May, but I'm sure that will be subject to availability as well, because everyone and their brother is going to want to get some of those. So I don't know. I mean, I think, Frank, you could probably start thinking about what kind of antibody testing you'll want to do with the group, what parameters you want to use. If you want to, like, you know, they're already talking about at our hospital, like, do you want to test healthcare staff every week, you know, just to make sure, or how is it going to work? You may want to start thinking about that. But even if you did have the antibody test today, that's the problem. You don't know. It could be positive, but you don't know what the level of antibodies mean. So it doesn't have a lot of value for you clinically out in the field. Just because you have antibodies doesn't mean you're protected. Similar to the flu, also you could get flu A and get a different type of flu A in 2 weeks. There's nothing to say just because you had flu A in one season, you can't get a different type of flu A. And we don't know if there are subtypes of this virus or mutations yet.
So that's a long way, Jason, of us saying we don't know, we're not sure, and the test we want isn't available yet.
No, that's what I figured. Thank you.
Okay, does anybody else have any other questions? Okay, Ray just signed on. So Ray, do you have anything? Ray?
Ray's probably figuring out how to unmute himself still.
No, he is unmuted. Hold on. Ray? Oh.
While we're waiting for Ray, I'm curious from people over the last week or so, what's happened with your call volume as well? Have you noticed a decline like we have in the ER, or are you still running around like crazy?
We're definitely running around less, but I have a different take on the decrease. You guys are right. We're not seeing the cardiac like STEMIs and strokes and things like that. And my guess is that America is killing themselves at work. And now that everyone's home from work, all these horrible things aren't happening to them, even though they're stressed out about money, maybe.
Maybe they're eating better with their home cooking too. Who knows?
Maybe, but we're just not seeing the MIs and the stress and the other things like that we were seeing. We're just not, which is great.
Our numbers are about half they were the peak right now.
Yeah.
And the cardiac arrests are down from, I think the high we had was 9 or 10 a day. We're down to seems like 2, maybe 3 a day.
Yeah, that was for a while there. The number of arrests was like, it was amazing how many arrests there were in a day, even in the hospital too. Like, I don't think I've ever seen numbers that high for single days.
Okay, does anybody have anything else?
Dr. Raybridge, I just have a question.
Sure.
Is there any more clear information on like what the status is with any sort of drugs that they're using to try to treat this?
Yeah, so I can tell you that the things that everyone's talking about that are part of trials, like hydroxychloroquine and azithro, nothing's been published that's been positive for them recently. There's been a couple studies that are starting to come out that show that really there's minimal, if any, benefit. The bigger trials are still pending, but we also haven't seen great results with it. I don't think it's going to be the magic cure that people were hoping for. It may help a little bit. And then remdesivir, which is that antiviral, you can only get that through the trial that's being run by Gilead. And that data should be published in another couple weeks, but also so far not great results with that. We're doing convalescent plasma. A lot of places are doing that and starting to see positive results with that, so we think it may help. It did help with SARS and MERS, so we think it may help with that too. With Ebola, it didn't really help, so we're hopeful. I think a lot of that is the timing of when you give the plasma. I think, waiting till they're in cytokine storm in the ICU may be too late. I think that, now some trials are looking at the timing of maybe we need to give some of this stuff earlier and see if it helps. But there's no specific treatment yet that's been shown to be truly shown to be beneficial, other than like anecdotal stories from certain people and places.
Ray did 2 questions over the chat. He said, we're having an increase in our personnel testing positive. Is the hospital seeing the same?
I am hoping.
Yeah.
I am right now with COVID, so yes.
Oh.
Yeah, we've tested, I think this morning's number, we've tested something like 320 employees, and we've had like 170 positives or something like that.
Symptomatic?
Most of them were very mild. Yeah, they had to be symptomatic to be tested. Most of them were very mild, like, I got a headache and a cough or something like that. And then some of them tested negative, but still don't feel well, and are because the hospital's allowing them, when they get tested, to go home for 2 weeks. So I think there's some incentive for certain employees to do that, but the ones that have tested positive have all been symptomatic. So I don't know, testing yourself if you have no symptoms, I'm not sure what value that is, because then if the test is positive, is that a false positive? Were you just exposed to it? Do you really not have it? I don't know that anyone knows what to do with that data.
Okay, and the other thing Ray said was we're going to put out a more stringent self-test monitoring system in the next few days. So I know Nelson is working on that, and it's going to obviously involve temperature monitoring. I guess each partner is going to take the temperature of the other person, and so on in the stations and at the headquarters.
I mean, I realize you guys are wearing PPE when you go into calls and stuff, but when you're riding around in a truck with your partner, are people wearing masks, not wearing masks? What do you guys, I mean, I guess theoretically your partner could be, a carrier and then become symptomatic in a couple of days and you've been exposed to them, but I don't, what's the practice been?
More.
I've been wearing a mask.
So I think that's what they're putting out. They're going to put out that, the recommendation is everybody should be wearing a mask, a surgical mask, when they're not rendering patient care, and an N95 mask when they are
That's what
rendering.
Ray says in the chat, that's
Yeah.
supposed to be what everyone's doing, so.
I'm pretty convinced that most of our emergency department exposures and illnesses have been secondary to hanging out in the break room and being, wearing a mask is hard all day.
And not good hand washing.
Hmm?
And not washing hands well. That's
Yeah,
probably the number one.
yeah.
Because in RER too, we noticed the people who got it mostly, the largest group of sick people in RER were our secretaries, our AAs, right? So they don't wear gloves, they're touching the phones, answering the phones all the time, handling all the papers. I don't know how frequently they wash their hands. Every one of them got sick.
Okay.
Now, along the lines of that PPE there, this is a little not EMS, but in my office in the police department, Jeff, we've had four people test positive. Now we're staggering tours, so there's not as many people in the office. We're all kind of keeping our distance. But I mean, we're going through hand sanitizer, at an enormous rate. But should we be sitting in the office with masks on?
I would, especially if there's gonna be other people around there.
We do.
Okay.
Yeah, we do for sure.
We're wearing in the ER, like the staff, they wear masks their entire shift.
Okay.
I was, so I still got it.
Yeah. I mean, they're walking around taking everyone's temperature like every hour and a half. So.
Well, that's probably a little excessive, but
Yeah. We're doing temperature monitoring in the hospital. It's useless. I mean, in general. I think I was talking with one of the nurses that were assigned to the temperature monitoring station, and all week long she had one person show up with a fever. So I don't really know how effective that is as far as use of resources, but I mean,
the thermometers are so variable anyway.
I mean, well, obviously you could be completely asymptomatic with your tests. I will tell you just from my personal experience, my presenting symptom was sneezing, the nasal congestion, that's it. I didn't have any other symptoms. So I came to work because I had allergies, right? So I came to work on Friday and I didn't get a fever until Saturday. So, I mean, you could be walking around with some nothing symptom that you really dismiss and, exposing your partner or whatever. So,
Can you still taste things? Can you still taste things, or did you lose your taste also?
No, on Sunday.
Yeah.
No.
Yeah, I lost my taste on Sunday too.
That's
And
been a
everything-
pretty consistent symptom, and for a lot of people, it's been early in the symptoms.
So on Thursday, I started sneezing, and on Friday night, I had some Crystal Light for dinner. I poured powder in my water, and I drank the water, and I'm like, oh, I didn't add enough powder. So I got up and I added more powder, but I didn't think anything of it, and I didn't really lose my taste for real until Sunday.
Okay. Any other questions? Anything else we want to discuss?
When can
Is
I
there
get my,
any sort of guidance on like the at-home tests that might be coming out?
At home.
Like, should they be doing
Someone
that instead of like going to a lab to get it done, or is it not going to matter too much?
Well, I
this
think
moment.
it may increase your call volume again once they start doing that, and then they get
Yes.
their at-home positive test results. They'll freak out and call you.
Yes.
But, listen, it's going to make it, I think, easier for people to test in the future, in the next few months, like when things start going back to normal a little bit, that, you know, people probably have these tests and, oh, they don't feel well, they'll test themselves, right? So that they know sooner. But I mean, functionally, since we don't have a treatment that you have to take day one to get better, then I don't know that it matters other than them knowing and staying away from other people.
But even more just for, you know, EMS providers.
But
To do
I think we want the
yourself, or-
quantitative. I think really what we have to have is the quantitative. I don't think any of this at-home stuff is going to really help us.
Yeah.
Okay, Paul, did you have a question?
Is anybody on here qualified to give me a haircut?
We're working on that. Arlene supposedly has a contact. I've been pressing her for it. So
Well,
after,
take the razor out of the bag for the monitor, and you'll be all set.
Oh,
My
okay,
friend-
thank you.
My friend Lauren does hair. She
you've been
has-
saying that.
She said, I'll give everybody her phone number. She said that she'll come to her house. She has an N95. She has masks. And just as long as you're clean, she doesn't mind doing that. Or you can come to her house. So,
Okay, I'm first.
Right.
Remember, I asked you 2
She
weeks
does
ago.
men and women.
I asked 2 weeks ago. My son looks
And
like
I- and I
Elvis.
would
A
give
state
her
like
phone
Georgia
number.
or something where those are all essential businesses.
Yes. Okay,
And then my
anything on topic? Anything on
I have a-
topic?
I have a question about, I guess it goes back to the cardiac arrest. If we're in a facility, it's an obvious arrest. We've got a doctor who signed off from the facility. Do we still have to contact medical control?
Yeah, under the protocol, there's no requirement for you to contact. Everyone likes to call medical control to pronounce, but there's no
Yeah.
requirement in the protocol that you have to do that.
Don't be
Right.
saying that.
And the
Well,
It's true.
They said that, and then we put out something after that that said that we were still required to call you guys. So I'm still not sure. If it's an obvious death facility, we've got a physician. Do we need to?
If there's a physician there who's going to sign the death certificate,
No, the facility has a physician who they've already talked to, like one of these nursing homes, you know, or somebody who's been on hospice or whatever.
How are you going to have documentation of that? In other words, I'm not, all I'm saying is, let's say you say that in your report and then turn around and say, I never said that.
Well, in my report, I usually say staff reports that Dr. So-and-so has been notified and will sign death certificate.
Right, but what I'm saying is, so then they say they never said that. And again, Jeff's right. This particular version, where I mean, this is like, I don't know what version of this cardiac arrest protocol we're looking at now, but if we go back to the original one, there was a little thing about in certain situations that you had to call medical control for permission not to work the patient. I think that's what people are referring back to.
right?
This one's a little more clear cut, but all I'm saying is, you know, I wouldn't count on somebody, you know, you writing that someone told you something unless you have, you know, a tape of
Look,
it, or
you're welcome to call medical control at any time, right? It's usually a very short conversation.
Yeah. And the ER physicians love getting these,
Yeah.
by the way.
I mean, how often have you heard one of us say, "Oh no, please work up the patient and bring him in immediately"?
so.
Okay, I just wanted to know for clarification, because I know we did get that one that said we don't have to call, but then you said go ahead and call anyway. So
No, that was in the situation. I mean, I have to go back and look at it, but it was outside of the parameters of pronouncing. That's the question. I think it was the age of the patient. Like they said, it had to be over 65. And we had a situation where somebody under 65 was pronounced and they didn't call medical control. I think that was like the very first one
It
of
was
these
like
that
one
we
of the
did.
very first arrests, way back at
Yes,
the beginning.
right.
Yeah.
okay.
So, yeah, it was.
And are we expecting a surge? You know, I know Fauci's been saying that we're expecting that in another 2 weeks there may be a surge on this. Are we planning for another surge in Rockland?
Well, the only
Yes.
thing I would say is you had Passover and you had Easter.
So by the end of this week, we should know about
Yes. At the end of this week and through next week, if it's
Yep.
going to happen, that's when it's going to happen.
that. And then other than that, it will happen as things open up. So
Yeah.
yes, everyone's planning for that. You know, stockpiling of PPE should be going on now. Everyone should be trying to replenish their supplies to make sure that they're ready for that second wave if it happens.
And we have been getting some supplies now from the county. We actually, yesterday I went up with Angel and we picked up probably our best run of supplies so far, but it's nowhere near what we've used, but it definitely is helping. Any other medically relevant questions?
Just remember with the medical control thing, no one can ever fault you for calling medical control, right? So if you're not sure, pick up the phone. You're never going to get in trouble for calling.
Okay.
Okay, anything else medically relevant? Just from a operational standpoint, we did receive in the 2 new trucks. One of them had to go back because there was a problem with the ignition override. So it's back at 1075 getting looked at. Bo will be back tomorrow. I'm sure he's going to work on getting those in service and stuff like that. As far as these sessions, I guess we'll have one again next Tuesday at 2 o'clock. Again, we got great, we're up to at 1.35 people. So we're getting great things. Jessica will work on getting this posted up onto CenterLearn as soon as she can. And we'll work with the region again and getting medical control credits. Some of you are signing on via phone number. Again, we're not gonna see who you were. So please make an account with Zoom. And if you're doing it from your phone, download the Zoom app onto your phone and then sign in through the Zoom app so we could actually see your name so you can get credit for it. And I don't know, does anybody have any other questions about anything at this point, medically or operationally?
Frank, at some point, this will begin to translate because, you know, obviously the ALS in-service, the traditional in-services are suspended for now. At some point, this will...
These are all medical control contact.
Yeah, so at some point, this will translate into what we need for our REMAC. And
you will get whatever, whatever this translates into. I don't know how long this one's been going on, but Jessica's been, basically rounding it in 15-minute intervals. So I think last one was 45 minutes. This one looks like it might be a little longer. One was an hour and a half. So whatever this translates into, the region said they would give you credit. If you're on the live one like this, that's why I need you to sign in with your name. You actually get medical control credit. If you're not signing in with your name and you're going to then look at the one on CenterLearn and play that one back and take the test and all that, you would get physician contact. So, it's better for you to obviously sign on this one and do it that way. What I haven't been able to work out is, and I'll ask Jessica and maybe Jason to look at it, is there a way of us giving you CenterLearn with just a test without having to see the whole video? Because those of you who sat through this don't really necessarily need to see it, all over again. But just a lot of things going on, but we will work on that. And this does seem like we get a lot more people participating than anything we've ever done, call audits or ALS and services and stuff. So, okay, anything else? Okay, everybody stay healthy, and I will set one up again for next Tuesday at 2 o'clock, as long as that's good for the medical directors. And thanks. Okay, everybody stay safe.